Okay. Our next debate, adjuvant systemic therapy, either before or after, should be given to all patients undergoing complete resection of metastatic colorectal cancer to the liver. We have two debaters here, one who has evolved just a bit since his early years as a shiftless surfer on the West Coast and settled into a more responsible lifestyle, and another one who is really going after yet another big fish today, I think. Can we do the questions? So should we routinely be giving adjuvant systemic therapy to patients undergoing complete resection of colorectal liver metastases? Yes or no? This is where do you think we're starting? The next question, which agent has demonstrated to inhibit liver hypertrophy with portal vein embolization? Inhibit liver hypertrophy with portal embolization. Of the four agents shown, which is the one that is shown to inhibit hypertrophy? There's a phase 3 EORTC trial randomizing patients with 1 to 4 resectable liver metastases to perioperative chemotherapy versus surgery alone. This is going to be a cornerstone of this debate. Perioperative chemotherapy resulted in lower complications, increased progression-free survival, increased overall survival, or increased toxicity associated with irinotecan. Specific hepatic toxicity associated with chemotherapy is associated with which chemotherapy? The leucovorin dose of FOLFOX, the rate of chemotherapy infusion, the number of cycles of chemotherapy, or the comorbidity of the patient. And finally, and not quite sure where this question came from, but you should know the answer to it as a part of your general, the waves at Mavericks can rise to 60 feet for surfers. Mavericks was named after the road leading to the beach, the restaurant in Half Moon Bay, a beer, or a dog. Just remember, this will be the last question, the last piece of data you get from this meeting. And in a slight departure, Nick Petrelli is going to start with the con position.
Damn, what goes forward? Oh, I get it.
And you have 8 minutes on the clock, so 6.
Okay. Dr. Coit, Dr. Morrow, members, and guests of the Society. Surgery alone for colorectal hepatic metastasis is enough. Dr. Mitchell, Charles, Posner, we do not need chemotherapy. As a matter of fact, we do not need any agents. Now, the key points of my portion of the debate are two issues. One, hepatic resection is the only potentially curable treatment for colorectal liver metastasis. And secondly, overall survival is the endpoint that matters. Now, we've known since the late 1970s and early 80s that patients with resectable disease, either solitary or multiple metastasis, do better than those who do not undergo resection. And in the 70s and 80s, the 5-year overall survival was 30%, but in the 21st century, because of better patient selection, better preoperative and intraoperative imaging, and better surgical techniques, that 5-year overall survival can be as high as 50%. And certainly this sophisticated audience doesn't need to know the details of the criteria for resection, but certainly a negative margin resection, minimally 2 adjacent liver segments spared, note no limit on the number of metastases within reason, as long as the vascular inflow and outflow and biliary drainage are preserved. And a key issue here is that the remaining liver volume must be adequate. So the normal liver parenchyma, that's 20%, but you add chemotherapy, it ups the ante to 30%, even higher, and obviously in cirrhosis even further. And of course today we have stage hepatic resections, portal vein embolization for a future liver remnant, usually less than 20%. Now, one of the key issues here is that specific chemotherapy-associated hepatic toxicity is well defined and well documented. Irinotecan can cause steatohepatitis, oxaliplatin, sinusoidal or vascular injury. And as far as the biologics, we are still learning about the biologics, or certainly we know that bevacizumab as an anti-VEGF agent can hamper liver regeneration. However, these effects can have surgical mortality, especially with prolonged course of chemotherapy, in general 6 cycles or more. And up-and-coming members of our society, Nick Voté, Tim Pollack, Eddie Abdallah, and even the older generation of Steve Curley, sorry Steve, I had to get that in, have shown that 90-day mortality can also be increased with these newer agents. Now, Dr. Posner, why would we want to turn normal liver parenchyma into this? We don't need chemotherapy or biologics. And there's one other issue that's important here. Systemic effects of systemic chemotherapy. In the 20th century, as you see on the left, diarrhea, febrile neutropenia, stomatitis, nausea, and vomiting. But in the 21st century, these agents of the monoclonal antibodies, the chemotherapeutic agents of irinotecan and oxaliplatin can cause everything from myocardial infarction, neurotoxicity, you can read those, cerebral hemorrhage, tracheal stenosis, and bowel perforation, leading to a poorer patient quality of life. I'm going to talk about 3 prospective randomized trials, 2 in the adjuvant setting, post-hepatic resection, and 1 in the perioperative setting, the EORTC trial. I'm going to talk about a pooled analysis of 2 adjuvant trials. You can see these trials here. Both trials randomized patients to 5-FU-leucovorin versus surgery alone, realizing that oxaliplatin or irinotecan were not part of these trials, but I'll get to that. In that pooled analysis, when one looks at the overall survival, there was no difference between the patients who received chemotherapy and those patients who got surgery alone, and even progression-free survival was not improved between those 2 groups. Now, let's go to the EORTC trial, a well-designed prospective randomized trial by the EORTC. The PI was Bernard Longinger, a member of our society. Randomized patients with 1 to 4 resectable hepatic metastasis to either surgery alone or 6 cycles of FOLFOX, followed by surgery, followed by postoperatively 6 cycles of 5-FU-leucovorin and oxaliplatin. And when you look at the progression-free survival, there was a 9% improvement at 3 years in progression-free survival in those patients who had received perioperative chemotherapy as opposed to surgery alone. However, in a late-breaking abstract last year at ASCO, there was no difference at 8.5 years of follow-up in overall survival between these groups. So perioperative chemotherapy did not add anything to this group of patients as opposed to surgery alone. And when you look at the postoperative complications of this trial, the postoperative complications in the perioperative group were statistically significantly increased over surgery alone, and not innocuous complications, biliary fistula, hepatic failure, intra-abdominal infection, and the need for reoperation. And the differences were statistically significant. And how good are our agents that we use today? They're not good at all. Again, by Bernard Longinger and his group, this looked at complete response of colorectal liver metastasis post-chemo on CT scan. What does it mean? Does it mean cure? Absolutely not. 66 lesions disappeared on CT. At surgery, macroscopic cancer was seen in 20. There was no lesion in 46. Out of the 15 sites resected out of those 46, viable tumor was seen in 12. And in 31 sites left in place within a year, in situ recurrence in 23, leading to 80% of the metastasis not cured. And here's the last nail in the coffin. This is looking at the volume of future liver reserve before and after portal vein embolization with bevacizumab. On your left, you can see in patients who got portal vein occlusion without bevacizumab, a nice increase in volume hypertrophy. Look at what happens to patients on the right getting bevacizumab. This difference was statistically significant. Why would we do this, Dr. Posner? And then there's the cost of chemotherapy. An 8-week course of FOLFOX is around $12,000. If you add bevacizumab to FOLFOX, it doubles the cost. An 8-week course of FOLFIRI plus cetuximab is close to over $30,000. Now, my colleague and friend is not concerned about cost, but he's been seen over the weekends driving in Chicago in this little baby. So what is the value added of chemotherapy? Value is cost and quality of care. Chemotherapy increases patient costs and healthcare costs, increases hepatic toxicity, increases systemic toxicity, poor quality of life, no improvement in overall survival, leading to no value. A final note to the surgical residents and fellows. Accomplish what you want to do in such a way that it makes a difference. Chemotherapy doesn't make a difference. Thank you very much.
We will continue the New York smackdown here with past President Posner.
Thank you, Dr. Coit. Well, strap yourselves in. To quote from one of the movies that I love, Nick, you can't handle the truth. So let me frame the debate for you. The questions are very obvious. Is there substantial risk of recurrence following resection of hepatic metastases? Is there effective chemotherapy? Is there compelling evidence for efficacy in this setting? And what is reality? So let's look at the substantial risk of recurrence. I agree with Dr. Petrelli that when you look at those resected, they do much better than those that are not resected. However, you have to understand the fact is that most individuals will recur. So 5-year survival is only 40%. Maybe Dr. Petrelli thinks that's adequate. 5-year disease-free survival following hepatic resection is only 25%. And that means 75% will recur. So is there a substantial risk of recurrence? The answer is definitively yes. Excuse me. Is there effective chemotherapy? I don't know what world Dr. Petrelli is living in, but in the last 10 years, we have improved survival from 15% to now 30% with our new agents. One only has to look at those patients who are deemed initially unresectable to see the effects of the chemotherapy that we have in the modern era. And in fact, when you take patients who are initially unresectable, treat them with chemotherapy, and then resect them, you can see that their curve closely approaches those patients who are initially resectable. And when you compare them to those that are unresectable, the evidence is compelling. In fact, the value of actually getting an R0 resection is no longer compelling. And when we treat patients, they have the exact same result if they have an R1 resection as an R0 resection. So is there effective chemotherapy? You bet. Is there compelling evidence for efficacy in the setting we're talking about? Well, it's obvious. This is the ERTC study. And when you look at all resected patients and look at progression-free survival, there's a statistically significant benefit from the addition of perioperative chemotherapy. If you look actually at all patients who were with the intent to treat of this trial, they also benefited with respect to the addition of chemotherapy. There are potential disadvantages. I'll focus on the ones that Dr. Petrelli mentioned: toxicity and post-resection morbidity. We see all of these things with the use of our chemotherapeutic agents, and Dr. Petrelli mentioned them. However, let's grow up. We know how to deal with this. First of all, there's no mortality increase with the use of these agents, and if we limit them to reasonable cycles of chemotherapy, there is in fact little increased morbidity with the use of chemotherapy. And in fact, we know you do not have to drug these patients with chemotherapy, that with reasonable cycles of chemotherapy that are limited, we get the exact same response as if you treated them persistently. In those individuals have a occult low disease burden, as those patients with stage 3 colorectal cancer, everybody in this room would treat those patients with postoperative adjuvant chemotherapy, because when you look at the yellow box here and compare it to the dark blue box above, you see a substantial benefit with occult metastatic disease. Well, we're in the same setting. When you look at the trial from France, there was an improvement in disease-free survival with the addition of chemotherapy post-hepatic resection. And when you look at overall survival, agreeably, there's no statistical significance, but there's a 10% benefit. When these are pooled, as Dr. Petrelli mentioned, into one trial to try to improve our ability to detect a difference, when you look at progression-free survival, again, you do see a trend towards a benefit. It's not statistically significant, but Dr. Petrelli, as we get older, I guarantee you that 10 more months may make a difference to both of us, especially you. When we look at overall survival that Dr. Petrelli has focused on, you will see that, again, there's no statistical significance with the addition of adjuvant chemotherapy. However, now we're talking about 15 months of added benefit in terms of overall survival. And when you look at a multivariate analysis of that trial, you will see that in both progression-free survival and in overall survival, that the addition of chemotherapy has substantial and statistically significant benefit. Now, some will say, well, these are in patients who have the worst prognosis. Well, in fact, if you take the best players, and all of us would agree those are patients with solitary metastases that are metachronous, when you look at a trial, not a trial, but a database that has over 1,400 patients, when you look at both overall survival and you look at disease-free survival, if you do not receive postoperative chemotherapy, your chance of doing well is significantly diminished. And when you look at it in terms of actual numbers, there's a 10% benefit in overall survival that is statistically significant. So is there compelling evidence? You're damn right there is. Well, what about reality? The fact is there's been a paradigm shift. The very old paradigm, which is the one that Dr. Petrelli adheres to, and you can see why, it would be surgery. The old paradigm is surgery plus postoperative adjuvant therapy. The new paradigm is preoperative therapy followed by surgery. Reality is we don't control these patients, and all of them are in fact getting preoperative therapy and post-hepatic resection chemotherapy. I want to thank you, and I look forward to Dr. Petrelli's rebuttal.
Well, there's only one point I agree with my colleague on during his presentation. He made the mistake of actually comparing the subject matter this evening to advanced unresectable disease and converting those patients to resectable disease. I totally agree that the agents that we have today that can take an individual with unresectable hepatic metastasis and convert them to resectable disease, that is good. Those patients indeed do as well as patients who initially present with resectable disease up front. But that's not the group of patients we're talking about here. We're talking about patients who present initially with resectable disease. And in those patients, the toxicity is sky high, and there really is no benefit in terms of overall survival. The other issue is we definitely do need new agents. The last 40 years in advanced unresectable disease, we've gone from a median survival of 6 months to 22 months median survival with these new agents. 40 years to do that, and not one patient with unresectable advanced colorectal carcinoma is cured. All those patients undergo palliative therapy with the agents that we have today. So the real crux of the matter here is surgical resection and avoid the toxicity, avoid the cost of these agents which have absolutely no impact shown by prospective randomized trials, which is our gold standard in overall survival. Thank you very much. Time is up. Time is up. You can't, no more. That's it.
Can I have my rebuttal slides, please? Well, now you're in trouble. Now, there are a group of individuals in this world who say one thing and do another. We can call them hypocrites, which is a bad term, and I love Nick Petrelli, so I would never do that. But you use another term, flip-floppers. In healthcare reform, there was an individual who instituted in his own state but somehow forgot about it when it happened to be taken into a nationwide venue. There are also individuals who in the past have demonstrated that they actually believe in chemotherapy for every single patient. But all of a sudden, they have flip-flopped. Now, the resemblance here is striking, I think. They both have handmade Italian suits. They're both wearing lapel pins. And not a hair on their head is out of place. Nick's a little bit more silver-headed than Mitt Romney. Nick, as you know, is the chair of the NSABP GI Committee. And under his auspices, there's been 2 trials. You will note, under the randomization for patients who undergo hepatic resection, in both arms there is chemotherapy. And while he claims that overall survival is so important, the primary aim in the first trial I showed you, C09, was progression-free interval. The second study, C11, also randomized patients who had resectable, I'll repeat, resectable hepatic metastases and randomized them to hepatic resection followed by chemotherapy or perioperative chemotherapy and hepatic resection. Are you peeing in your pants now?
No, not yet.
Okay.
Not yet. Not yet.
I will point out that the primary endpoint of this trial, again, was recurrence-free survival. So there are individuals who flip-flop, say one thing and do another. And then there's another group of individuals. And in the end, they always prevail.
We're running a little bit late, so let's go into the questions. Let's see how we did with the debate. Adjuvant systemic therapy should be given to all patients undergoing complete resection for metastatic colon cancer to the liver.
That was great.
Nick.
Well, I think, I think you have to be careful here. I mean, I think there are a subgroup of individuals that I'd be very concerned about, especially if you're an advocate of giving it perioperatively, and that is diabetics, where we know steatosis is an issue, individuals with cirrhosis. So I think, just like Dr. Bolt said on his, all patients, we don't like to say ever and never,
Right.
in medicine. So,
Yeah, I like to
But
say
there's
data.
a strong
Mitch likes to say
predilection
data,
towards
so-
chemotherapy here.
yeah.
I'm going to have to go to the next question. Inhibiting liver hypertrophy after portal vein embolization, which agent? Okay, I think we got that. Next question. The phase 3 trial randomized patients with 1 to 4 resectable liver metastases to perioperative chemotherapy, and this trial resulted in one of the following. Two to three. Okay, we've got that progression-free survival. There was a small improvement in knowledge gap. Last question. Next last question. Chemotherapy, hepatic toxicity is associated with which one of these factors, being the dominant factor? Very good. Excellent. Cycles of chemotherapy don't overtreat. And the final question. The waves at Maverick can rise to over 60 feet for surfers. Who would know this, right? Mavericks was named after one of the following. What?
People who enjoy life.
People enjoy life. Yeah. Pretty even, Nick. Thank you very, very much for your attention, for your participation. 2 announcements, please leave.
The answer is a dog.
A dog, sorry, 4. Leave your keypads and stay for the business meeting. Those are the 2 announcements. Thank you very much.